and a very good morning to everyone here. Today we'll be talking about to demonstrate the adjunctive role of intravitreal anti-VEGF injections in rapid resolutions of intraocular tubercular granulomas. So choroidal tuberculomas are the most common forms of intraocular TB. The high vascular supply of the choroid favors this location of the tuberculomas to form. Most cases lack a definite tissue evidence, and the management is relied upon clinical presentation, systemic involvement, and response to treatment. Most cases are unilateral, but there can be multiple cases also. Yellowish with indefinite borders located in the posterior pole. They have a varied presentations in terms of hemorrhage, stry, or exudative retinal detachment. There is minimal associated inflammation. Tubercular subretinal granulomas are responsive to ATT. It has been proposed in literature that increased levels of VEGF may be responsible for the vascularization of these granulomas. Pharmacological inhibition of the
Timer is not working. Timer.
Should I continue? Pharmacological inhibition of the VEGF pathway limits the spread of the MTB, causing regression of the new vascularization, thus achieving a host-directed therapy along with the ATT. In recent years, there have been multiple reports of successful use of anti-VEGF for the treatment of tubercular granulomas. So we'll be discussing a couple of cases. So this was a 25-year-old male, a student who presented with diminution of vision in the left eye for 1 month, which was painless and progressive with no aggravating and relieving factors and no contributing significant history. The vision in the left eye BCVA was 360, IOP anterior segments was within normal limits. When we see the posterior segment, the inflammation was minimal, and if you focus on the red arrow there, you see a massive subretinal mass almost engulfing the disc, and you can see the disc being absolutely choked with multiple hard exudates at the macula. This is the corresponding OCT showing the fluid there and an amalgam of multiple hyperreflective foci here, suggestive of a strong inflammatory reaction that's going on. So we revisited the history. Father had pulmonary TB 2 years ago and was treated for the same. Among the battery of investigations that we did, we found a positive MAN2, a positive TB quantiferon gold, and a suggestive chest X-ray. We took a physician referral, and ATT was initiated along with the steroids, and we gave in this intravitreal anti-VEGF plus dexamethasone plus moxifloxacin injection under mannitol cover, and AC paracentesis was done. We gave 2 doses at 14 days apart. We monitored the patient for clinical picture, IOP, BCVA, vitals, and blood sugar. So this is after 1 week of post-injection, and you can already see, you can make out the disc features, and the granuloma has started shrinking. The edema, which was massive that time, has come down, and then we re-injected the patient, and here we see a near normal OCT. The disc features have come back to normal as compared to what we had started with an absolute choked disc. The BCVA was 6/6. This is all happening within a month of initiating therapy. Case 2, 36-year-old male as a shopkeeper, diminution of vision in the left eye for a month, no known comorbidities, no contributing history. Again, the left eye, 6/60 BCVA, IOP anterior segments all within normal limits. Now here we see there is this mass here, which in contrast to the other one doesn't look that aggressive, although the OCT shows us that the disease is pretty much active. So we went through our protocol, and the positive investigations we found was positive MAN2 with the quantiferon gold and X-ray. Again, ATT initiated with steroids. We gave in the injections along with the mannitol and the AC paracentesis, 2 doses, 14 days apart, and monitored the patient. So we can see that within the first injection, the granuloma is almost gone, and the OCT has come back to near normal, although the fluid is still there. And followed by the second injection, where this is almost like a normal fundus photo, and the OCT is also returning back to normal anatomical ranges. BCVA was 6/9. So ocular TB is a form of extrapulmonary TB presenting as uveitis in endemic countries like ours. The classic histopathological finding is epithelioid cell granulomas with a central area of caseating necrosis. VEGF is a known biomarker for TB, and there have been reports of that the serum VEGF level of patients in active TB decreased parallel to the improvement of the disease. VEGF is highly expressed in the inner macrophage layer, the active layer that surrounds the necrotic core, and the bevacizumab normalizes the granuloma vasculature, reducing hypoxia and enhancing the penetration of ATT. Paradoxical worsening of IOTB due to an immunological reaction is known. The reason why steroids may need to be increased to intravenous corticosteroid therapy. In the last decade, there have been multiple reports highlighting the adjunctive roles of anti-VEGF. Agarwal et al. Showed in their study the non-regression of granuloma was responded to the injections of bevacizumab plus moxifloxacin. So did Bansal et al. In their study. And Ivan is in our first case, as we saw that the disc was choked. This one, he again showed how the injections of bevacizumab helped reduce the disease pathology. So anti-VEGF drugs ensure equal distribution of all therapeutic agents in the granuloma, thus significantly reducing the chances of MDR, TB. Moxifloxacin preferentially accumulates in the macrophages, the active zone, so the intravitreal moxifloxacin is used to target the active component to have a higher penetration of the disease. The highlight of the paper was the use of intravitreal bevacizumab plus moxifloxacin along with the standard ATT plus steroids. So this was our study to demonstrate triple therapy in resolution of intraocular TB granulomas, which is a targeted therapy promising faster results in anatomical and clinical resolution, although larger numbers are required. Thank you.
So how can we be sure that the systemic treatment is working or the aggressive intravitreal dose is affecting? These things are doing in conjunction.
Yes, ma'am. So, ma'am, as we know, tubercular granulomas, whenever we start treatment, the standard is to give ATT along with the steroids. And there have been multiple literature reports that yes, this is there. But then there are these factors of MDR TB that comes in. And then there's this factors of non-resolution, like the exudative retinal detachment persisting and the edema persisting, the disc being choked. So it's a longer protracted course. There have been studies which have shown VEGF levels to be increased, both systemic and in aqueous aspirates, although the vitreous biopsy would be a better analysis, but aqueous aspirates have shown high levels of VEGF. So when we are giving this anti-VEGF injections, ma'am, the VEGF is going down. Also, it is reducing the vascularization that is happening along the granulomas. So it is shrinking that, which is helping in more better disease penetration, therapeutic penetration to inhibit the drug. And there have been serial reports where when we did aqueous aspirates in the patients post the anti-VEGF, we found the VEGF component going down in the aqueous with, as we saw the study, the anatomical reduction of the granuloma, ma'am. Sir. 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 Yes, sir. Yes, sir. Yes, sir.
Hemopoietic disturbances, parasitic infestations,
Yes, sir.
focal sepsis.
Sir.
Because I am a very old school of thought. I have passed my MS from SM Medical College in 76.
Sir.
So you give a lot of lectures on this eels.
Yes, sir.
And you, those old things, they used to give the anti-tubercular
Yes, sir.
drugs in this.
Yes, sir.
Have you seen the case of eels?
Yes, sir.
So what is now the modern modality of the treatment of eels now?
So basically, as we know, EELS is the diagnosis of exclusion. And once we are confirmed that this is okay, we are dealing with a patient of EELS. So yes, we go with the normal protocols of giving the ATT and the steroids. Depending upon the clinical picture, if the vitreous hemorrhage is clearing up, the FFA lights up neovascularization or capillary non-perfusion areas, we go in for an aggressive form of a laser. If there is an associated TRD, tractional retinal detachment, we would warrant a VR surgery. If it's a non-resolving VH, sir, then we plan to go ahead for a vitrectomy, and if the retina is attached, we will compound it with an intravitreal anti-VEGF.
Thank you very much. Thank you.
Sir.
So, Dr. Indranil, is there any role of FFA in this?
Yes, sir. So FFA would be helpful to corroborate the diagnosis. Yes, we did not, but in our cases, we did not go for the FFA here. I mean, both FFA and ICG would have been helpful, but we don't, one, we don't have an ICG access. And the FFA, we did not go for because we were more towards to, once we got the OCT and the clinical pictures, sir, so we were more prone to go in for a therapeutic role. And the FFA was planned as a plan B if the first, if the response wasn't coming as desired. Right. So that was the FFA plan, sir.